It just sounds so silly when you say it out loud, doesn't it? This is what I say to people when they're putting those things forward. And it's the same with shockwave. The other one is shockwave. So shockwave is by having this treatment that is basically like a hammer on the tendon. It's supposed to lead to some sort of, response in the tendon that's going to lead to some sort of signaling that's going to improve pain. The evidence is piling up that it doesn't seem to add anything over and above placebo.
If you want to understand more about tendon injuries, your research will inevitably include the work of Professor Peter Malliaras. Peter is a physiotherapist, clinical researcher and educator based at Monash University in Melbourne. He is widely recognised as one of the world's leading voices in tendinopathy and is frequently cited as the #1 expert in the field. His research has transformed how we assess, load and rehabilitate tendons, with more than 150 peer-reviewed papers that shape international guidelines and everyday clinical practice. Today, Peter combines world-class research with clinical expertise to help athletes and non-athletes alike recover and stay active. I'm honoured to welcome Professor Peter Malliaras to the Be Better series.
How are you, mate?
Hello, Peter. How are you?
I'm good. I'm good. How are you doing?
Yeah, not too bad. Well, we've got a heat wave at the moment. I won't complain because I know it's you get it much hotter over there, but we're not built for it over here.
What's the temperature
So it got up
at
yesterday
the
to about
moment?
32, 34, which we
Yeah,
don't
yeah,
have
yeah. That's
aircon.
pretty hot for London. No, yeah, yeah, that's pretty hot for London. I remember living there. That it all sort of falls apart when it gets to that sort of level, doesn't it?
To be
With
honest,
all
though,
the buildings the way they are.
yeah, we do
Mm.
fall apart if we get extremes of anything, though. A little bit of snow and the country comes to a gridlock as well.
Yeah,
So yeah.
yeah, I remember
Um,
that. I remember having being able to stay home from work a couple of days because I couldn't get there when it was snowing.
Yeah, and my
Um,
cousins in Canada think it's mad, but then they've got big trucks with big old wheels and like they're set up for it. We're
mm,
just not set up for
mm,
anything but just
mm.
middle everything. Um, so
Which works most of the
firstly,
time. Now, tell us more
but
about your story. Tell us more about
yeah,
your story.
oh,
You've had
okay.
some
So
health concerns.
yeah, so I started off in as a sports therapist back in 2008. So I finished my degree in 2008, did that, worked
Mm,
as a sports therapist right up until COVID. Then when COVID hit, I just couldn't afford to keep because I was hiring out a place, so kind of had a bit of a
mm,
breakaway.
mm,
And then I was doing an MBA at the time and had this pain in my
mm,
stomach. Kind of
mm,
ignored it for the first day.
mm,
Second
mm,
day was the only way I can describe it to people is that not only was it the worst pain I felt, but it wasn't right.
mm,
So I went to the hospital because I just thought this really doesn't feel right. And then by the time I'd got there, I was in so much pain, loads of morphine, and then I woke up 2 months later.
mm.
I'd been in a coma for 2 months with
Wow.
necrotizing pancreatitis. Um,
Wow.
that then
Wow.
caused multiple organ failure.
Mm,
And yeah, so
mm.
then I went on a journey
How do
of
you get something like that?
so there's basically two mechanisms. They say it's almost a 50-50 split between uh, gallstones, and a gallstone can come out and block the bile duct, which is what happened with me, or alcohol consumption. And they said that when they see cases, it is either that or that.
Mm,
And then on the scans, my gallbladder is just full of stones. So yeah, I was actually really lucky. They at one point they gave me 1% chance, pulled my family in to say goodbye, everything. So it was bad. And then kind of I got to see the other side of physiotherapy because obviously we treat people, but we're not usually that badly injured ourselves, fingers crossed. But I had to start by learning how to sit up, breathe myself. I'd lost over 80% of my muscle mass, so I had to. They used it, it was quite funny actually, because I've never seen it. It's not funny for the people having it, but I thought it looked like a sack barrow when they came and just lifted me up, and I would just stand for a few moments and then lay back
mm.
down. So from that point all the way through to where I am now. So I thought kind of as a good,
So how long off work and off like general doing stuff for you?
so it took me a good, I would say year to 18 months to feel Like it was really overwhelming. So even I remember going into Tesco's, into the supermarket,
Mm,
and I
mm,
broke down crying. It was just
mm,
overwhelming. There was just too much
mm,
going on. So
mm,
all of that kind of
mm,
waking up in ICU is pretty scary stuff. So it took me
mm,
quite a long time
mm.
to get over it. And then I've spent the last 2 years teaching. So I've been teaching science in a secondary school, and
Fantastic.
now making the jump back into physio.
Good on you, mate. Good on you.
Yeah, yeah.
Really
So
good.
I
Really,
start
really
at
good.
Birmingham University in September doing a master's in physiotherapy. Um,
Yeah,
so yeah,
yeah.
so now I'm
Good on
making a
you.
jump back in.
Good on you. That's really, really great. Did you end up finishing your MBA?
No,
MBA.
halfway through. So I've got a postgraduate certificate in business.
Yeah,
Didn't finish
yeah.
that.
Mm,
But now
mm.
I'm making the jump back into the health world that I've
Yeah,
been away from for
yeah.
about 5 years.
Fantastic. Fantastic. With renewed vigor and enthusiasm.
Yeah, definitely. I mean, I loved my sports
Mm,
therapy degree, but I found that there's lots of doors
mm,
closed when you've not got a physiotherapy
mm.
degree.
Yeah,
Obviously, you can't get HCPC registration, so you can't take on
yeah.
insurance patients and things like that. So I
Mm,
thought, while I'm kind of making
mm,
that re-entry, I'll give myself a couple of years just to upskill and do the physio.
mm. Yeah, no, fantastic, fantastic.
Excellent.
Yeah, that is really good. So let's crack in.
I thought a good way to start would be for me to tell you what I see the classification as, and then we can get started with the questions, and you can kind of correct me as we go.
Sure, sure, we
Yeah,
can do that. Yep.
perfect. Okay, so joining me today, I have Professor Malliaras, who is a physiotherapist and researcher, not just researcher, but director of research at the School of Primary Healthcare at Monash. Is it Monash?
It is Monash. Yep,
Yeah,
it is.
Monash Musculoskeletal Research Unit and Deputy Editor of the Journal of Physiotherapy. He's currently ranked as the top tendinopathy expert in the world. So thank you for joining us, Peter.
Thanks a lot, Brad. Thanks for having me.
So first off, I thought I'd go back in time to when I was studying first, and I was kind of 2005 to 2008. So we were just off the back of using the term itis, I believe. So rather than using the term
Mm,
tendonitis, we had
yeah.
started to be introduced to the term tendinopathy, and we were kind of more swaying towards an understanding of tendinopathy of being more of the tendinosis type presentation. So I remember being taught that tendon becomes straw-like, granulated.
Mm,
Um,
mm,
then we'll get a neovascularization, so
mm.
that oversensitization. That's about as far as I've got. So would you be able to clear up the term just before we start?
Sure. So basically, we used to think that it is an inflammatory problem, just an inflammatory problem that is due to, you've done a little bit too much to the tissue, and the tissue then becomes inflamed and wants to heal. And you go through this inflammatory response, just like when, say, you have a muscle strain. But we know now that that's pretty much completely wrong, that idea, because it's not really, um, we don't really have much idea about what goes on in the tendon around the time that you get pain. And we know that the pathology extends far back from the point of pain. So if the point of pain is here, we've got this pathology brewing for a long time before. So maybe, and there's two theories about pain. One is that the tissue is becoming overstressed and metabolically active over months or years before, and then at some point it triggers to pain. Uh, and then it could also be that there are it triggers to pain for some reason. So that's really the theory is more that pain is some sort of metabolic process going on inside the tissue that leads to some sort of healing, potentially at some point adaptation, but also you get pain whilst that is happening. And pain is there for a reason to say, look, this tissue is undergoing changes, trying to get stronger. We need to protect it at this certain time. So that sort of then opened up this whole new sort of avenue of thinking when we realized that this is pathology is completely, well, not completely, but quite largely disconnected from pain. That this is not just an injury where you've got this inflamed tissue. That's a tendonitis. We can't just treat it with, and then people started realizing that the typical treatments you do for inflammation, like rest and anti-inflammatories, don't work. They don't work at all. In fact, they probably make it worse if you do just that. So then that's when we started thinking about tendinosis, because we saw on scans, and if you look at under a microscope the tissue, it shows signs that the tissue cells are dying, and you've got the collagen is all disorganized. So people started thinking, oh, this tissue is just completely, it's almost going down a pathway where it's just dying, and it's not good. But now we know that's completely wrong as well. So we're wrong pretty often with these things. That's one thing you learn when you're doing research, that what you thought a few years ago is not the case. So basically now we know that, now it's sort of come full circle. We know that there is inflammatory signaling, but we still don't call it tendonitis because that's not accurate. It's too simplistic to say this is just a tendonitis. It's a very complex cascade of signaling and metabolic changes that are associated with tendinopathy, and it's also leading to tissue changes which look like they could be quite degenerative, and changes in cells. The funny thing is, and the more recent thing is, that actually a lot of these things can actually reverse. And what we thought was a tendinosis and a degenerative tendon that can't get better, maybe in a lot of cases it can get better. So that's also changed the thinking around that. So it really is a dynamic problem that is best described as pain and dysfunction localized to the tendon. That's probably related to this complex signaling, and partly inflammatory signaling within that as well. But that's obviously not a good label, so we call it tendinopathy, which is a lot shorter.
Yeah, and so that's changed even since, like I said, so when I studied, kind of I had this image in my head of particularly when we start looking at the shoulder tendons, of this kind of where the tendon's getting pinched, it gets kind of wrung out and dried out, and had this kind of brittle thought process to the tendon. So again, another kind of, just to help me to understand a little bit. So when we're starting to get this tendinopathy, and we're convinced that that is the root cause of the pain, is the tendon itself getting weaker? So by that I mean, if we had something that we would classify as a tendinopathy, if we keep going and keep loading it, is there a chance that we'll get a complete rupture, or is that not the case?
Okay, so it's a difficult one to answer, that one, because it sort of depends on the context and also on the tendon side. So if you look at, let's take for example the Achilles. You start to load the Achilles, it gets to the point where it starts to get, we could say overloaded or overused. You start to have changes to the cells and the tissue, and then you get pain at some point. It doesn't seem to progress and become progressive to the point where it tears and then it ruptures. Ruptures obviously happen in the Achilles tendon, but most people that rupture haven't had pain before. Whereas when you go to something like tibialis posterior, supraspinatus, and gluteal tendons, they are different. They seem to sometimes, we know from rotator cuffs, probably the most well documented ones, where you can have a tendon that has a partial tear that is a full thickness tear from top to bottom, and then it progresses to a full partial tear of the whole thing. And sometimes they're not painful, like the Achilles, they rupture without pain, but sometimes they're painful. So it's a bit different, and it's the same with gluteal. Gluteal, you can have tears of, say, one of the glutamine or glutamide, and they then progress, and it's the same thing. You've got a painful problem, but it seems like it progresses. The other area where it seems like it progresses is tib post, because some people have that acquired flat foot that just progresses to a complete tibialis posterior rupture. So I struggle, to be honest, to answer the question for patients when they say to me, is this going to get much worse to the point where it progresses to the point where it's going to rupture? And I usually say to them, it probably isn't. But then I'm thinking to myself, maybe it is. So it's very hard to predict. I think on balance, most people are not going to keep progressing and progressing and progressing. Even if you look at the cuff literature, where they've done cohort studies with hundreds of people, there's a small group that keep progressing to rupture. So it's not as if it's a common outcome to keep progressing.
Yeah, no, that does help because that's the mindset of patients and for us, and the worry for us is like, should we really protect this? So I'm kind of skipping to a different.
Sorry to interrupt you, Brad, but I think that's a really important point, and that is the mindset of the patient. The patient, and that's what we've got to be careful of, because the patient will think that this is going to keep on progressing, it's going to get worse, and it's going to rupture. And that's why as clinicians, we have to be able to reassure them that this is very unlikely to get to that point. Okay. Very unlikely to get to that point where it's going to just keep progressing and rupture. Okay. So
because that does lead on to, because there was a question that I was going to ask you, which is about, again, when I was taught about tendinopathies, about how we actually start to elicit a response from the tendon. And we were taught that actually when you're doing things, so let's keep with the Achilles, when you're doing your heel drops, you want to go into pain. You want to get the patient to be stretching the Achilles so much that there is an element of pain. So that was going to be a question that I was going to ask you a little bit later on, but might as well jump in here, was then at what point do we load versus pain? So obviously someone's coming to us with a painful tendon. Do we always need to have a period of rest, or do we push straight into loading? Where do we start?
So we sort of know pretty well that if you load a tendon that is, it's I guess again it's quite variable, but we know that if you load a tendon that is painful, you run the risk of making it more painful. And that's just a very simple way of explaining it. If you load someone who's painful, then the risk of pain goes up. Now, is there a cutoff? Is sort of the question. Because I think in tendinopathy, we think about there's a cutoff. There's like 3 out of 10 or 5 out of 10 is safe. And, above that is not safe. I don't actually think that's the case. So I don't think we've got a cutoff that is universal. So some people, you load them and they can really flare up a lot. And they haven't got much pain when you're loading them. Some people, pain is a really good guide. So if you do things that are 3 out of 10 or less, like the textbooks say, then it's likely to lead to a good outcome, and eventually they take more load. For some people, it's not a good guide, and you can you get stuck on a certain level of pain, you can't progress them, and we end up not using pain as a guide. So yeah, that the question that you're asking goes to whether you've got pain as a reliable indicator of rehabilitation progression and also severity. And it's difficult because it's not so clear. I'm not sure if that's getting to what you're asking though. Is that
Yeah,
what
no,
you're?
no, that's great
Mm,
because it's
mm,
knowing, do we have that period where we completely rest them, get them away from activity fully, and
yeah,
then when we start to load, can we deal with a bit of pain? Because I think,
mm,
especially as an early career clinician,
mm,
you're always a
mm,
little bit worried of pain. And as much as
yeah,
the patient is coming to you
mm,
in a state of kind of worry that something's going to
mm,
go wrong, you're also worried, I don't want to give this patient loads of exercises that are pushing them into pain and then something make something
mm.
worse. No, so
Let
that
me
is
let
that's
me let me clarify something that I think will make it easier for us to understand. Um, the thing that is important to look for is the load to pain relationship. So how related is load to pain? And the way that we do that is we look at progressive loading tests and we see how much pain goes up with those loading tests. We also ask them about their response. So is their response proportional to the loading they're doing? And we're getting an idea of whether, first of all, is load a trigger for their pain? And then how and is that proportional trigger? So they're the two things that you've got to find out. So there are some people where pain load is not the trigger; it's something completely different. So you don't, and when you find that out, then you don't have to, and that goes back to your original question. You don't necessarily have to reduce their loading to get them better, because loading is not the problem. It's something else. It could be their lifestyle factors. It could be their general health. It could be psychological factors or other things that are causing issues or maintaining their symptoms. So once you work out the load, how strong that load to pain relationship is, it tells you how much you need to load manage them, and it tells you how much you need to look at load as a way that is going to be a guide for rehabilitation.
and this goes to how I feel about things kind of it's almost the more understanding you get, the less you understand, and the more nuanced it becomes. Which, yeah, so following
Mm,
guidelines helps massively, but there is a huge element of
mm,
being able to kind of uh, play with the
mm.
boundaries of where pain starts and really kind of have that level of
Yeah,
yeah,
mm.
ability to tweak
Absolutely.
things.
Yeah.
Yeah.
The guidelines are not so helpful sometimes, for sure.
So would you use any tests kind of like comparing good to bad, like we do with range and things like that? So would you just use simple tests, kind of strength tests like that?
Mm. You mean like when I'm assessing, say, a tendon patient, what sort of things would I use to
Yeah,
grade how bad they are?
yeah. Well, so I mean, more like let's keep with Achilles. So if I could maybe do
Mm. Mm.
a set of 20 really good single leg calf raises on my good leg, would I then work
Yeah,
the bad
yeah.
leg to that side and try and make sure there's a balance there, or are we just going completely on what that leg can do? Does that? I hope that makes sense.
Um, um, I that's a really good question. And it's going to be a combination of both, I think. So sometimes, so say you've got an Achilles patient and you want to know whether they've got enough capacity in the tissue, in the system, in their leg, and just the strength is where it needs to be. We could, it's always helpful to have an idea in your head about how strong this person should be. The problem is we don't have good evidence to back that up. So that sort of comes from experience of seeing people. Uh, you can always use the other side, but the other side's not a good marker because we know that side could be affected by that problem itself or from other past problem. So, so that's always a risk with using the other side. So I prefer to have a target. So say with an Achilles, there'll be a target where that we're trying to get with an individual that we'll have throughout the whole rehab course, and that's also serves as a motivator for them as well.
Yeah, brilliant. And then just kind of working backwards from there. You want to get running again, so let's work backwards from that point. Okay, cool. So leads us on nicely. What are the biggest misconceptions that you think still exist? So I told you my one of I
Mm,
was very much taught eccentrics. So keeping with the Achilles, it would be up with both legs, down with one, into pain,
mm,
kind of anywhere within
mm,
kind of 3 to 5 on the pain scale. So what are the misconceptions that persist in rehab circles that you've seen?
so misconceptions from a patient or from a physio point of view or a
Either, but
practitioner?
either and both, yeah. So
Yeah.
things that you see and hear that you think, oh, maybe
Mm,
that's
mm,
something that's not really helping our cause in the
mm.
tendinopathy world.
Um, there's quite a few. There's things like there's things like one of the ones you hear a lot is just allow, you need to focus on the kinetic chain. That's one that I think I agree to some extent, but not if that is the key thing that you're doing. So loading the tendon is going to always be part of what you're going to be doing. So there's no, and I think the reactive degenerative model, the continuum model is probably partly to blame for this because they talk about a reactive tendon where it's just overloaded. Just calm it down. There's a reason that tendon's overloaded, and it's not just because of kinetic chain strength. Uh, so loading of that tissue is probably always going to be part of what's needed when it's got to that point. Um, Another one is, and I guess this is going to sound like a contradiction, but it's the sort of reverse of that, and that is that the only thing we need to do is load that tissue. So some people will say, okay, all you need to do is just calf raises. All you need to do is just get that tissue really tolerant. And that is also simplistic. But we need to look at how the person, we need to look, and there's probably two things that I focus on that would be things that you need to do as part of treatment. One is look at how they move. How do they move? What sort of postures do they get into with their sport, with their running, with their walking? How is that impacting on what is going on? Um, and the second thing is what other contributing factors are there for that person, not just the tissue strength. So there's those things that I think um, people will have tunnel vision and just calf raises. So someone will see an Achilles and that's pretty much all they'll get. Um, the other, what else is there? Another one is doing lots of manual treatments or injections or treatments like that. So that's a
There's
classic.
Yes, there's two there in those that I'd kind
Mm,
of been told that were wonderful. So the first one,
yeah.
I can't remember this. I'm pretty sure that I was on a CPD course back in like
Mm,
2012 or something like that. And what they were talking about was that there there would be a fat pad, and then from the fat pad we'd get this infiltration of this neovascularization. So the treatment technique was to then fire
mm,
high pressure saline solution to almost kind of rip the roots away, like you would ripping weeds out
mm,
of a flower
mm,
bed. So it rips these roots
yeah.
away, and the pain's gone. So that was one,
Mm.
and the other was failing that you could, for instance, with the Achilles, you could get behind the tendon and strip behind the tendon manually. What are
Mm.
those completely out there?
It just sounds so silly when you say it out loud, doesn't it? I mean, it just sounds so, improbable. And this is what I say to people when they're putting those things forward. And it's the same with shockwave. The other one is shockwave. So shockwave is by having this treatment that is basically like a hammer on the tendon. It's supposed to lead to some sort of, response in the tendon that's going to lead to some sort of signaling that's going to improve pain. I mean, how simplistic that, that sort of thinking is, how can something like that replicate the cascade of changes that we see when we're loading or in normal life? And pain is not just the tissue, we know that as well. So how these things can, uh, I guess, pass that first test of is this going to work at all, is one of those things that is frustrating. Having said that, I did use Shockwave for a long time in my career, and I used it. I was always skeptical about the mechanisms and how it worked, but it was something that we did see short-term benefit from in clinical practice. So we used it. Then we started doing our own research in it. Now we've published in it, and now over probably last year and a half, I've not used it because we've shown with our own data as well, and the evidence is piling up that it doesn't seem to add anything over and above placebo effect. So yeah, look, it's really it is. There's lots of stuff out there, manual therapy, and again, it's there's a place for it. There's probably things that it can benefit, but overall, I think the simple treatments and progressing those, looking at someone holistically, how they move, um, uh, how their tendon functions. There's no substitute for those types of approaches, I think.
I do feel when I go to the a physio, an osteo, or whoever I'm going to see, I have to have a little bit of soft tissue though. Otherwise, I don't feel like I've really been treated. So a little bit of soft tissue, I think, helps people to just feel like they've had something done.
Yeah,
Whether it's
I'm gonna spoil your party there, Brad. I don't
oh,
agree with you. I think I I I hear that so many times from clinicians that they're thinking, oh, you've got to do something because the patients expect it. But I think you've got to set the expectations of the patient. And I'm probably in a fortunate position though, because most of the patients I see have done all that before. And they come here and they've done all that, they've done everything, and I don't really need to convince them that they need something different. So that's it. That's also a very fortunate position that I'm in, where they're not, looking at that type of treatment. Because my
so I
wife,
so I can piggyback on that, can I? And I can say, well, Peter Malliaras told me not to do massage, so I'm not going to do it.
Well, I was just going to tell you a story about my wife, which might change your view. She basically says to me, I can't believe that people pay to see you with the stuff that you do because all you do is, talk to them and give them exercise. Why don't you do any hands-on treatment for them? So she's trying to get me to do hands-on. She goes to people that do hands-on treatment. She doesn't
Okay.
like coming to see me. So I think there is, I mean, there's clearly some real benefit from manual therapy, but I don't think it's necessary.
Okay.
So I'm not saying there's no benefits, there's definitely benefits, but it's not absolutely necessary. And some of those benefits are really about therapeutic relationship as well.
Yeah, and I mean the whole placebo effect isn't something to be kind of completely poo-pooed either.
Mm,
I mean it
mm,
the fact they
mm.
feel a bit better, they move a bit better, that's got to be good, right?
Absolutely. I couldn't agree more. The question is how much you're willing to pay for that, just for that versus things that can give you placebo like exercise, but also give you maybe other benefits as well. So I think it's a question of where you focus your attention overall.
Yeah. Okay, brilliant. So our chat's been productive because we've got through a few of the questions I was going to ask anyway, which is great. Okay, so in terms of progress, we would monitor that with aiming towards our targets. That answers that question. So working backwards from where we're trying to get them to, and that's how we'd monitor our progress. Um, when it comes to any practical tips, Is there anything that you would give as a tip to a clinician that they can just start doing straight away?
Um, you mean like straight away, as in changing
Yeah,
their practice overall,
yeah.
or?
So something where you could just say to them, right, okay, next time you see someone with a tendinopathy,
Hmm,
this is my top tip. This is
hmm,
Professor Malliaras' top tip for the day.
hmm. Um, I would probably say it would be make sure that you have make sure that you have an objective assessment of their strength or capacity. So, and that could come in various forms. So, for example, it could be that you get them to, say, we're talking about Achilles, you get them to do an isometric hold in a plantigrade position, but you get them to do that with body weights, and then you get them to do it with 10 kilos, then 20, then 30, then 40, and you see what capacity they have and where they fail. It could be that you've got equipment like force plates and you can do an MBIC test. It could be that you just do a calf raise test, but you do it really well. I think we need to have some level of knowing what the capacity is like. And we need to, because that's one of the key things that we do in our profession. We make sure that people have the function they need to, get over these problems. So that I think we need to do really well. So get into the habit of treating it like a test that you really need to make as reliable as possible, and you do it well. Because most of the time, people will do a few with an Achilles patient, do a couple of calf raises, but not really spend the time to do it properly. So that would probably be the one thing.
Do you know what? I'm not going to say any names because I'm not sponsored. But you've reassured me that I've not just wasted money. I've just bought a couple of different dynamometers where I can then get the iPad out and show patients
Yeah.
exactly where they are in
Mm.
terms of their force production. So that's
Yeah.
set my mind at ease. I haven't
Fantastic.
wasted a hell of a lot of money.
No, 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 no. They are very useful. And I think one of the reasons they're really useful is for buy-in from patients. Because if you can demonstrate that they've got a problem, they're much more likely to stick to the exercise you give them to address that issue that they have. So they are quite useful.
Yeah, fantastic. Thank you very much. That's good to hear. Um, from the patients themselves, is there anything that you wish that they understood a little bit more? So you just alluded to the fact you're seeing people that have been really
Mm,
kind of
mm,
frustrated by previous
yeah.
treatments. They're coming to you quite far
Mm,
down the line. If we were to go to a patient and we go to them right at the start, if they understood right at the start, what would be helpful to them?
mm. Yeah, look, I think it's getting through those messages about, okay, what is this problem? What is it that they've got? It's, they in their mind, and we sort of alluded to this earlier, they're thinking they've got this tissue that is overloaded and it's going to get to the point where it's just going to get worse and worse and worse and worse. And they're not going to be able to walk, or it's going to rupture, or something like that's going to happen. So it's really just being able to explain to them that that is very unlikely to happen, and that this can get better, and what that recovery is going to look like. I think that's really, really important. But it's hard. It can be a challenging thing to do. Uh, and I think we've got to also recognize that patients, they do want to know about the pathology. So they want to know what is going on in their body and what it actually is. They don't want people saying to them, the pathology doesn't matter, because that's not going to be helpful. They want you to acknowledge the pathology and explain, what's going to happen to them, and that's really important. I think what you see is sometimes see people just not really considering the pathology, or writing it off, saying, "Yep, you don't need to worry about that. It's not, we're going to be treating your pain," but that is a really important part of it as well.
Excellent. I'm not going to keep you much longer. If I could do one more question, I wanted to
Sure,
do,
sure, sure.
yeah.
Yeah.
So, you piqued my interest with the shockwave therapy, and I'm been guilty, especially before I was a sports therapist and I was working in gyms. We can all
Mm,
jump on the next fad, can't we? So I think
yeah.
coming off the back of the 90s, where people were just getting back into the gyms, the early 2000s and into that period, everything was something new. It was now we're going to balance on a ball and we're going to do this and we're going to do something more convoluted each time. So,
Yeah.
um, what is something that you think is a trend or a fad that you would put in your room 101? Something you'd love to get rid of?
Hmm. It's a
There's
good
all sorts of
question.
things used for, so
Yeah.
we're big on things, aren't we? Like foam rolling, kinesio
Yeah.
tape. There's all
Yeah.
sorts of things that we use as,
Mm,
again, I
mm.
think lots of patients love to come out of clinic covered in
Yeah.
kinesio tape. It looks great.
It does. It does. Yeah. Look, I think there are so many things, Brad, that could fit into that category. There are so many things. Um, I think I think it's probably ones that are a little bit more fatty, probably in the tendinopathy type area. Um, there's things that people do in other countries, I think, more so than probably the UK and in Australia. So there are things like laser, for example. There are things like that. Like the other one is probably PRP. So PRP, we know that PRP doesn't have any supporting evidence. There's no evidence supporting the use of PRP compared to placebo, yet it is pretty much the most common injection that we have for tendinopathy at the moment. Okay, so even though there's no evidence to support it, and that's around the world, and it's because it's such a good cell because it is a biologic, and people talk about stem cells and activated, cytokines and all that sort of stuff. So it just is a really good story for patients. So a lot of my patients would have had PRP before they come, and that is, I think, one of those ones that probably we could do without completely.
I
Yeah.
love it. Thank you very much.
Mm.
So, big thank you for joining me. Thank you for sharing all of your knowledge. It's been brilliant.
No problem.
And
No problem. Thanks for having me. Thanks very much.
thank you.